Okay. Hello, everyone. A bit late. I didn't know I was supposed to set up myself, but you know, everything works out in the end. We are all emergency physicians, and these kind of situations happen where you have to do it yourself. So hello, I'm Robert Östman. Thank you for the invitation to come and speak on Akuutveckan. I'm an emergency medicine physician specialist working in Helsinki, in Meilahti, and I also work in Porvoo hospital in Finland, which is about 60 kilometers east of Helsinki. And I'm going to speak a bit about my path to specialization. I got my papers last year in the summer and have now worked as a specialist for about a year. And I'm going also to speak about the what happened when we started training emergency physicians, how we started doing that in Finland in 2013, and what it looked like, and what it looks like today, what we do today, and of course, how I was trained. Okay, so this is pretty much my upbringing. As you can see, I was on the path to becoming an emergency physician already in elementary school with my beard, which was odd by many, and now then ER physician. But this is the real reason that I chose medicine. These are not the characters from the show, but you can probably make out what the medical show was that I was obsessed with in my youth. So that's Scrubs, if anyone was wondering. I thought it looked fun to be a doctor, so I decided to become one myself. I wanted to start with an anecdote of my first patient when I was a medical student. I was working in Vaasa Central Hospital, which is. Well, I was in the internal medicine department, and my first position was in the ED. So all student doctors were 2 weeks in the ED. And my first patient was my senior came in and said, "Okay, Robert, you need to start looking at patients. You've been here for 10 minutes. So you're gonna go see a patient who has vertigo." Okay. Yes, I've had my neurology course. I've heard of the word vertigo, and he told me to use Frenzel's goggles. Of course, thank you, senior doctor. I will use those. I'd never heard about Frenzel's goggles, so I went and took a look. And if you know the goggles, they kind of look like magnifying glasses. So this was probably what the patient saw. A scared-looking doctor, and not being able to focus. Also, if you ever tested to have these goggles, you need to be really close to something to see. So we were like this and doing the Dix Hallpike, and I came back to my senior doctor and said, no nystagmus. At least I couldn't see any. They're probably broken. And so that was pretty much it. But now with training and as a specialist, I know that a lot of being in the ED is also just being confident, just, portraying confidence. So nowadays I look like this. So now you can see the confident face doing the things. Yeah. So, emergency medicine training in Finland. We became a specialty in beginning of 2013, and then 71 physicians received specialist titles to begin with. And they gained these through their clinical experience in the ED from before, and then they also had to do a written exam, and then they were awarded emergency physician specialist just to start training the new physicians. And by 2024, we had 200 specialists in Finland, so a pretty good amount of people, doctors being trained. But since the beginning, the training has pretty much been divided into conservative patients or internal medicine patients, operative patients, anesthesia, pediatrics, and first response. So these have been the different specialties that we've done our rounds in, and time in. And then also, if you wanted to do something else, you could also put that into your like ENT or other specialties that could come in handy in the emergency department. The duration of training in Finland today is at least 5.5 years since starting your training. We have a mandatory 9-month primary care phase, which you do in the at least 6 months in the in the healthcare center, where you do your time, and then 3 months can either be done on primary care wards or in the ED, and then treating primary care patients. And also, to be accepted to the program of emergency medicine in Finland, you have to have prior clinical experience and prior research. This is you get points for your clinical experience. If you've done your primary health care, you get 2 points, and if you've done work in the ED, you get more points. And also, if you have a doctorate, you get full points with the research, and if you've done one paper, you get some points, and so on. This is just to classify how to get the applicants somehow rated. Then you also have to write a letter of motivation to the university or the professor or the people who are responsible for the training, where you pretty much just say something about using Frenzel's goggles or something like that. Then you have an interview with the professor and also other staff who are responsible for the training of emergency physicians in that hospital. In Finland, we have 5 university hospitals that are responsible for the training of specialists. And after that, if you've gotten through these monstrous difficulties of getting accepted, you also have to do a 6-month trial period in the ED, in emergency departments around Finland. You do them in hospitals that have been pre-accepted as teaching hospital, that they have. They've been accepted as hospitals that can train emergency physicians. And during that 6 months, of course, it's not reasonable that you have to learn to be an emergency physician. Of course not. But it's pretty much seeing that you are a physician that we can train to be an emergency physician. Are they motivated? Are they showing up on time? Are they, watching their phones and not checking patients? That's not good, if there was a question about that. But yeah, so that's the 6-month trial period. Yes. Also, we have a lot of evaluation today in the ED, how we evaluate our trainees. And during the 6 months trial period, you also do these. So since 2020, we had a large curriculum change in how we train physicians in Finland, or specialists in Finland. So it got changed from a time-based system that you had to do like 1 year of that and 1 year of that and rotate around, and then someday someone says, you've been a physician for long enough, now you're a specialist. So we thought, the thought process was that we need to have some kind of oversight, that people actually know what they're doing. So now it's more skill-based, that's the wrong English word, but that you're observed to be at least at the level that you should be for a specialist, if you get what I mean. So some kind of tools for these, we need to have some tools. So now we have, we use EPAs, or entrustable professional activities. I, by the way, have no idea if other countries are doing this. I don't know if how the Nordic countries do, but in Finland we do this. We have EPAs. Emergency medicine has 7 EPAs, pretty much different levels of patient. What if are they high trauma is one, critically ill non-trauma patient is another, and these types of things. And each EPA has to be completed during training. So during these 5.5 years, you have to do at least once every 7 of these, and they have to be on a level 3. They are leveled from 1 to 5. So you have to at least get some level. These EPAs can be either evaluated just by the doctor who's training you, or we also can use in these EPAs these tools, the Mini-CEX or the mini clinical evaluation exercise, which is pretty much observing someone evaluate a patient. We have the DOPS, the direct observation of procedural skills, that can be putting in a chest tube, putting in the arterial line, can be intubation, can be what procedure you want, pretty much. They're not standardized that these procedures are what we observe. And then we, as the last one, we have the case-based discussion, or the CBD, where the trainee has chosen a case that they've had during some time, and then we discuss together how the case progressed, what kind of patient was it, and these are kind of fun as a trainer to do with your young physicians, because you can also check how well they do their differential when they start, how well, if, okay, let's say a patient has a sore throat, give me 5 reasons for a sore throat, and then we can discuss, pretty much do a big thing about it. And so this is my favorite of these 3. Anyway, these can be then implemented into the EPAs, and yeah, so these are tools that we use, and there's a lot. They're on paper, and we scan them, and we have. When I was scanning all my papers, I think I had about some kind of 100 papers that I had to put into the university. It's a lot more than before when you just had to, yes, I was working at this time. Thank you. Yeah, so now it's a lot of papers and bureaucracy. Anyway. Also during training, we now have more standardized discussions with our trainees. We have start and end discussions during this trial period. First, in the start discussion, we pretty much lay out the ground rules. This is what we're gonna look at during these 6 months, and these are the skills that we expect for you to learn during the first 6 months. And then we have an end discussion where we look at did we get to the point that we wanted to have when we started, and are you accepted to start your real training, which is the rest of the 5.5 years. Also during, so when you get to the rest after the trial period, you have a discussion with your mentor or your trainer at least once per half a year, pretty much just checking in, what's going on, what are your goals for your next 6 months, what's your next rotation, what do we expect for you to learn there, and then just checking if the last rotation, what kind was it, and this type of thing. During our training, we also do leadership training modules, which are 10 study points to the university. The length of these vary. In Helsinki, we have 4 modules that are half a year per module, so you do 2 years of online leadership training. Yes?
How much of, is it full time, no? It's 2 years?
Yeah.
It's once a week?
Yeah, they're done online. So you per month you get one. You have like one assignment per month that you can do on your free time. You have to do it on your free time, and then, yeah. No, it's not. We're not in lectures for 2 years how to lead. No.
No, that's what I
Yeah, I'm sorry. Good clarification. Thank you. Yes. We also have theoretical training, of course. We have to have 100 hours of theoretical training that are conferences or education outside of our work, which could be conferences. We have mandatory school education that we have to go are the ALS course of the European Resuscitation Council, and then also the ETC course are mandatory for emergency physicians. And then we also need to have workplace-based training, which is at least 1 hour per week at your hospital that you're working in. And then you do a written exam at some point. 5 hours per week. That's true. Yeah, 5 hours per week. And then you also do a written exam, and then hopefully at some point you're getting somewhere. We still have rotations. So nowadays we have to have at least 30 months of adult emergency patients with diagnostics and treatment. At least 6 months of these 30 have to be internal medicine patients in the ED, and at least 6 months of surgical and trauma patients. Then you also have at least 3 months of pediatric patients, at least 6 months of anesthesia and intensive care. And then you have at least 3 months of pre-hospital care and ambulance service. The guidelines say that 1 month of these have to be an operational month, which I'm not sure what that means, but I guess it means that you have to be in the ambulance for at least a month. I'm not sure. I'm coming to what I did. Yeah. Okay, my path. How did I do this? I got my medical license from Helsinki University in June 2019. I was at that point already working in Porvoo Hospital, in the emergency department at Porvoo Hospital. But our training has to start. We can't start as student doctors, so that's not counted anywhere. You start when you get your license. So Porvoo is a small district hospital with an emergency department, but of course there's not really a lot of patients at one time. We have right now, I think we're saying that we have a rush of patients when we have 25 patients total there, so that's not really that big. But they also have an intensive care module with 4 patients. They can be intubated or not. But this was a great starter place for me. At that time, we weren't that big of a department, so it was pretty much me and 2 specialists, and me running around the ED because the specialists were somewhere else. So that was a good training ground to begin with. And also the intensive care module was really great to see how critical patients were treated after the ED, and just getting a picture of what that means. That was about a bit over half a year. Then I moved to Vaasa Central Vaasa, which is a city on the east coast, and they have a larger central hospital, and actually have the longest route to a university hospital from a central hospital in Finland. So they have to do a lot themselves with cath lab and thrombolysis and other emergencies that they have to treat. There I first started on internal medicine patients and also worked a bit on the internal medicine ward. I personally think that emergency medicine, when you're training, you should be sometime at the wards, just because it's good to see what happens to the patients after they've been to the ED, and having an understanding of that helps you to get the right labs for the next morning for the patient. I also did 6 months of neurology, which meant pretty much wards, but also treating patients in the ED that they needed a neurology consult. It's a small hospital, so after 2 months, my senior gave me the consultant phone and said, "Now you're the neurology consult." Thanks. Yeah, great. So yeah, but that was a really good training. You have to read a lot if you don't know a lot and you don't have that much support. So that was great. Pediatrics I did also for 6 months. The minimum is 3, but I wanted to do at least half a year per rotation. Pediatrics in Vaasa was everything from the emergency department, young child patient, or neonates, also in the birthing unit. And then when also the NICU was also part of my rotation, so I did some time over there. I saw a hand again.
Yeah, do you have any mandatory obstetrics?
No. No.
So it's just if you want to, you can do it.
Yeah. Yeah, of course you can do, but it's not mandatory to do obstetrics. So I was the guy standing outside the birthing unit, and then when I heard someone cry, I said, "Yes, great, I'm going to the ED." And if they didn't cry, then we ran. Yeah, pretty much. Then came the anesthesia, which I did for 8 months. That was in the operating theater, but also in the ED when they needed an anesthesiologist. I was sent there, and then also they had a pretty, I think it was 12 patient full ICU. Of course, not like a university hospital, but still, if it's far away and you have critically ill patients, then you need to have the option to also treat them. So I was working there, and then came my surgical rotation, which was fully in the ED with, of course, some operating theater also assisting and some ward. But the great part of Vaasa was that they have, in Finland, our first response system has started to also recognize the need for land-based units. We have, I think it's 5 or 6 bases with Finhems or the helicopter service, but also the central hospitals are starting to have a land-based ambulance unit with a doctor, and these land-based units are pretty much the doctors are supplied from the emergency department, so they are emergency physicians, and we had one of those in Vaasa. So I got to be an ambulance doctor for 6 months, which was really great. So that was my part. Then I went to do my primary care at the Grankulla Healthcare Center. I did that for 6 months, and then I came to the university hospital, where I did my first small trauma ED. We have a small trauma unit, which is pretty much it's primary care trauma. So like wrists, some basic ankles, and non-operative trauma, wounds, stuff like that. Surgical patients for a while, trauma patients, and then the anesthesia in the ED, which we heard Jani talk about, and then intermediate care is the right word here. I wasn't in the ICU, but in the intermediate care that we have in Meilahti, and then conservative patients also. So pretty much doing during this time, of course, when you're doing the rotations, you also do shifts in the ED. So you're not actually just on the surgical ward. You also do the shifts on pretty much every rotation that you've done before that. So yeah. So you're in the ED all the time. Yes, more questions.
When you do the rotation,
Yeah.
and you go back to the ED to do shifts, is that your normal working place, or do you go back as part of your rotation? Or are you the surgical resident during the application, or would you go back to the ED and become the usual ED?
Yes and yes. So, so if you're doing your surgical rotation, you're also doing like the surgical resident shifts, but your workplace is the ED, so you also do other shifts than the surgical resident shift in the ED. So you're just doing a lot of shifts, a lot of different shifts.
You never leave your apartment totally. You always
No.
have one foot
Yeah.
in your apartment.
Yeah.
But that's a very good thing.
Yeah, it is.
Because we can go away and be away for 6 months and I've been nowhere near my apartment.
Yeah, yeah, but yeah, we have it the other way around. So we loan people to other places, but we are also using them. We need them to come back and do our shifts. So you always have like your foot inside your home and going and doing stuff over there. Yeah. So what do I do today? Well. So now that I'm a specialist, I more supervise my trainees, and also when I do the shift work, I do patient work. So during the day, not so much anymore. Well, of course I do some patient work, but I'm more like the consultant, the guy walking around, looking at what the other guys are doing, keeping an eye out of if there's a critical patient. I'm often there. Either I take care of them or I keep a close eye on my trainee who's doing the work. And then the shift work in the ED in Meilahti or Helsinki is divided into anesthesia, internal medicine, surgery, or intensive or the intermediate care ward. So there's so that's how we divide. So about one shift per line per month. And then also in Porvoo, I'm in charge of the training in the emergency department. So what I do the same as I do in Helsinki, but also planning simulations, planning how the trainees are going their route in the training. And then over there, I only do internal medicine patients, because surgery hasn't yet we don't have the resource really yet to give them an emergency physician, and they're not really ready to start helping us come there either. But I hope at some point I get to change that and also start pushing our trainees into those at that hospital.
Sorry.
Yeah, of course.
It's just so interesting.
Yeah.
But when you say that you have these 4 shifts,
Yeah.
back anesthesia and the internal medicine, are you covering that shifts for them? Or are you?
No. Well, no. The shifts are because Helsinki University, because the hospital is so big, we have so many patients. We need to somehow get like you have to have some patients that are on your line. The shifts are for the emergency department. It's not. I'm not doing a shift for the internal medicine staff. I'm doing it through us. But it's just what kind of patients I see that evening.
So you don't see all of them? Like if I go and
Yeah.
in an emergency department,
Yeah.
we have emergency doctors, then I see all.
Yeah.
I'm different.
Yes. Well, I also look at undifferent. I hear what you're saying. It's we don't we have. We want our emergency physicians to have more like a broad view. So, but they still they're on this type of shift. So if these patient lists that they come in on, if they're internal medicine or surgery or whatever, they usually have at least one emergency physician and then also surgery or internal medicine, so what, working side by side. The EPs are expected to also look at other patients, and we do that, of course, because we like treating patients. But we still have our main responsibility that evening is our dose patients. But if you're doing anesthesia, of course you're doing the anesthesia things, intubating, putting IVs, arterial lines, whatever. But usually you also take a big part of the treatment of the critically ill patient. So if we're stocked, then I'll do everything. I'll take the patient, I'll intubate them, I'll do the workup, and then call, yes, ICU, of course you'll take him. Yes, let's go. Yeah. So it's broader than what it looks like, but still, these are your main thing tonight is to do this. Yeah.
Who decides which line patient ends in?
The triage nurses, pretty much. Yeah. So when a patient comes in, a triage nurse takes the first report. Okay, skull fracture, neurosurgery, or something like that, which usually means that one of the EPs goes and looks at them.
With emergency physicians in Finland, because it sounds like you have a lot of resources from other specialties.
I wouldn't say that we're missing. It's just that our system. It's progressively getting now. When we're talking about Meilahti, it's a long traditional big hospital. So you can't just say, okay, now emergency physicians are going to be at ED. Thank you, bye to everyone else. So it's gradually going towards us taking over. But we're working kind of side by side, yeah. And of course, if the triage has, they have a stomach ache, but then you see, okay, they're a Crohn's patient, so they actually need also more like an internal, so you can shift the lines. Of course, if it's an EP doctor taking care of them, you don't need to shift. You can just, whatever, they're my patient, yeah. So, but yeah, so it's a line of progression still. But what's happened during these 13 years since we started training doctors, and why is it looking like it is today? A big shift has been in Finland that we've gotten to a point where other specialties don't see us anymore as just triage doctors, but actually starting to see that it's pretty good to have people who can, treat any patient, not just like that kind of patient. But also a thing that's happened is work-life balance has started to be a bigger part of young physicians. They don't want to have long shifts every 2 days. They want to have shorter shifts. But that also puts a lot of pressure on the other departments to get people, because if you have from 8 shifts per week, you suddenly have 20 that you need to cover. Then you can't just do that by yourself. And then suddenly we have a specialty that's like, yeah, we can do a lot of those shifts. And suddenly we're morphing into taking over the emergency department. Also, as we've heard today, medicine is becoming more subspecialized every day. You have surgeons who are not general surgeons anymore. They're vascular surgeons, they're thoracic, whatever. There's a need for a broad understanding that's become clearer, and that's also showing in Finland a lot. But I think the challenge that we face is that the need for us is growing pretty at a big rate, and also for us then to start supplying the need. So that's a good challenge, but it is something that's happening. And I asked our head of department also what he thinks about the growth of emergency medicine, and he said that, which I thought was good. If you come in, if you're in the emergency department and you force yourself on everyone, yes, we're going to treat these, just go away, you don't know how to treat emergency patients, that's pretty much not going to work. What a better approach is pretty much to, do your work, and as we saw, the need is is coming along, and we're just taking the larger role behind their back, no, not behind their backs, but still. Another thing he said was the pepparkaksmodellen, which I thought was really good. If you have a gingerbread dough, and you know when you make the pepparkak, or you know you have the form and you put it, then it's a pig and it's something else. But this is kind of our patients in the ED right now with all our subspecialties. They just want the perfect pig. And then they take that part, and you still have a lot of dough that's falling, not getting the forms, and that's the patients that are slipping through the fingers that nobody wants, and that's where our specialty is the right answer, I think, because okay, they have a heart problem, but they also broke their leg. Well, you don't need 3 doctors. You need one who's looking at, okay, the heart attack is pretty much the big issue now, and then we can operate the leg later, you know. Yeah, but that's the pepparkaksmodellen. I thought it was pretty much. So I think the next steps that we have as a young specialist, I think the next steps that we're taking are pretty much that we already talked about. We want to stop drawing the lines, stop having internal medicine patients, surgical patients, and everything. You have ED patients. These are our patients, and then we choose who we need to keep treating the patient. But in the ED, there are patients. And as I said, there's an increasing amount. We need to increase the amount of ED physicians. One thing that I think will be the future is that we will be having emergency medicine specialists on all shifts, all time, 24/7, so that we also can ensure that the junior doctors are getting training all the time. As we go into more of a shift work based system, the training or the usual 2-hour lecture in Friday mornings means that half of our people are on our shift then. So the actual work training is going to have a bigger part, and then we need specialists. And then what I would strongly want is better interdepartment cooperation. Not this fight that we've been hearing about with anesthesia, that who's going to intubate the patients, or more like, okay, I'm intubating this patient. Okay, do you have a place in the ICU for them? Yeah, sure. Okay. Do you need help? No, I'm good. But just I'll call if it starts getting hard or anything like that. It's just cooperation more than just yelling at each other, which I think should be the road, because an emergency physician is not a surgeon or internal medicine doctor or an anesthesiologist, but also a surgeon or so forth are not emergency medicine physicians. We all have our skills that we need to get and work together to create the best patient care. That's my path and how we train, and my thoughts on the future in a mix of thoughts that I gave to you. Any questions? Yeah.
In Sweden, it's quite common to have an emergency doctor as a leading physician in the emergency department.
Yeah.
And you have that kind of role.
Yeah.
You have one that's leading, and is that an emergency physician anymore?
Yes, we call it senior physician for like which is an emergency physician in the ED. At nights there are intermediate ward shift workers who are not always an emergency medicine physician by training. They can also be internists, but they usually it's in our department that's supplying the senior, yeah, and they are in charge.
Also for the surgery, for the surgical patient.
Yeah. So pretty much their role is going around checking if all lines are doing well. Are there any rushes that we need to take care of, or how is DER staffed and so forth? Yeah.
I have a question from Denmark. You talked about a 6 months trial period. How many residents stop in that trial? Participants in Denmark, how do you accept?
I actually I wanted to have some numbers on how many we don't accept.
Or you say
Yeah, this is not the correct specialty for you. I'm not actually sure how many fail out, so to say. I haven't at least yet heard of anyone not getting
I
there.
have a supplementary
Yeah.
question, because I saw you with 200 specialists, and you have actually had the specialty for since 2013.
Yeah.
How many specialists do you expect? Do you want in Finland right now? What is the need? Do you guys know from Finland?
I think you have to increase double the number because
Double.
we are not enough.
Yeah.
And the smaller hospitals are in desperate need.
Yeah.
I think we in the big universities, we manage, of course, but the smaller hospitals are in desperate need.
Yeah, that's true. Yeah.
How do you handle the doctors who you want to exclude after 6 months? How do you get them out without destroying them?
I'll have a better answer when I have to do that someday. No,
Professor who takes care of it.
yeah.
It doesn't happen. No.
Yeah.
So I know a few cases.
Okay.
It's very important to be able to have people go to someplace else without breaking them down.
Absolutely.
But is it part of the understanding? Also, is it because in Sweden you usually have a 6 months trial, but that's for being unstead with that.
For your employment kind of a thing, it's not being washed out of the program, but it's rather for unemployment you start with a 6 month trial period.
Yeah.
But it goes for every job really.
Yeah, it goes. Yeah.
So for us it's no big deal. After 6 months there might not be any space in the department to continue, and then it's not a big deal because it's not that we think you're unfit. We might think that too, but what we say is we don't have space for you. You have
Yeah.
to stop after
But that's also a way for hospitals to kind of use our work.
Of course, yeah.
So you admit a lot of people for 6 months, but you can't really afford any or give them any official training after that.
Yes.
But that's a political question.
Great discussion and questions. I thank you, everyone. Yeah.